as well. So we are pleased to have Dr. Tanya TRINH with us from Australia. She's an exemplary cataract and refractive surgeon, and she has a lot of experience with the education as well. She's also on the RANSCO executive board and is a researcher and has published widely. So looking forward to hearing from Dr. TRINH on her experience with the Clareon IOL and how she feels it compares with the iHands.
Thank you so much. So cutting-edge IOL platforms, and when it comes to elevating visual outcomes and reaching patient satisfaction, I've been given the honor of following Professor Conan talking about our monofocal and monofocal toric platforms. But what is in these lenses for intermediate vision, and is it possible that we're leaving something on the table by not considering the intermediate capabilities of these lenses? How far can we push them? And I think that this is particularly meaningful for those practices where there is a price differentiation for the various different types of lenses that you're offering your patients. I am a consultant both in the public and the private system in Australia, and the vast majority of cataract surgery is still burdened in our public system, where we largely only have access to monofocal and monofocal toric lenses. And so being able to push the barriers in terms of the statistics that Professor Conan had placed up on the stage, saying that a vast majority of patients want some sort of presbyopia correction, but only 3% of patients are being able to access these. There is some role to play with when it comes to our monofocal armamentarium. So this is our disclaimer for today. Now, we should have a break just to talk about the Clareon platform, and certainly this is built on the fundamental principles of what has made Alcon lenses so successful since about 1994. And really, we've borrowed from the concepts of the biomechanics and the biooptics, and certainly for the patient experience, it's really been quite a premium outcome, with the Clareon platform then being introduced in 2017, and the intraoperative and postoperative experience for the surgeon itself, and sort of smoother unfolding, not a lot to say in terms of decentration, rotational stability. It really has been a platform that has paved the way for generations of cataract surgeons coming through. Again, you've seen a couple of these slides before. As a cornea surgeon, I like the fact that it is a hydrophobic acrylic and it has quite a high refractive index for corneal clarity. And again, some of these in vitro studies, if we're going to talk about the elephant in the room, is talking about what is the glistening profile of these lenses. Now, on the Clareon platform, as you can see here in these in vitro studies, the Clareon performs very, very well against its competitors in the same market, and these are demonstrating some of the lowest levels of glistenings in comparison. But not only are we looking at the glistenings, but we're looking also at subsurface surface haze. Again, a very similar study in vitro at the slit lamp. And the Clareon also performs quite well in terms of the haze intensity of what can be seen against its competitors. And the other parts about the lenses that I particularly like is that it's a fully usable optic platform in terms of the 6mm edge-to-edge profile. They have a proprietary edge so that there is less edge glare and dysphotopsia pertaining to that compared to our competitors. And not only were the ND-YAG rates already low on the Acrosoft platform, but they are significantly lower on the Clareon platform thanks to the shape of that edge as well in terms of having a continuous posterior barrier. But what of the Clareon monofocal's function? So what am I supposed to tell my patients if, in Australia we're quite lucky. We don't have a co-payment system, but we do have very generous insurance companies that will pretty much pay for whatever lens I decide that my patient needs to have. But that is certainly not the case in the public system. And I want to be able to tell my patients what is their expected function if I'm only limited to using a monofocal or monofocal toric. Now, we have had the definition of functional vision today in terms of what is the, what do we actually mean when we talk about functional vision? And when we talk about this, we're really looking at that 7.569 vision above the legal limit for driving, certainly in Australia, at about 66. So you're able to read comfortably on electronic devices, and you're able to read slightly larger font at about 66, which is generally a comfortable reading distance, but certainly keeping our small profile, small stature patients in mind as well. So monofocal IOLs might actually have more intermediate vision than we give them credit for. I'm going to go through 3 studies looking at monofocal lenses and what their intermediate capability is. And there is increasing recent interest into the types of lenses that might actually lend themselves to having more intermediate vision correction, and particularly the type of residual astigmatism that may influence the presence of more satisfactory intermediate vision, specifically with oblique astigmatism. Now, the first study that I'd like to highlight is by a colleague of mine, Smita Agarwal. This was a recent publication looking at intermediate vision specifically on the Clareon platform, but pitched as a monofocal IOL in general, and included toric lenses. So this was 63 eyes from 52 patients, assessed at about 3 months after surgery, as well as the first month, using the IOL in a satisfaction questionnaire to assess patient satisfaction, and then using a modified QVID score for binocular visual quality assessment. They also looked at other biometric factors such as pupil size and postoperative biometry under mesopic conditions. And when we look at this, the postoperative spherical equivalent was pretty much close to plano, 82% of patients within about a half a diopter of the refractive target. And when we looked at post-refractive cylinder, and in this study they were correcting anything above 0.75, average postoperative refractive cylinder was about half a diopter on either side of this as well, about 57% attaining that target. And specifically when we look at these group of patients, about 24% of those with postoperative refractive cylinder had oblique astigmatism, and that's a point that I'll come back to shortly. So most eyes, about over 70%, achieved an uncorrected visual distance visual acuity of about 0 or better, with a distance visual acuity of 0.2 logmar or better being maintained within about a diopter on either side of defocus. And when we look at the average monocular uncorrected distance visual acuity, it was pretty much close to 0 logmar, but when we looked at the intermediate, that actually fared quite well as well. So in terms of looking at in uncorrected distance visual acuity, this is obviously better than best corrected in 43% of eyes, but 17% of these were actually found to be two or more logmar lines worse compared to best corrected. But when we looked at eyes achieving intermediate VA of N6 or better, they were obviously lower than with distance correction, which would make sense given that we're looking at a slightly likely amyopic defocus here. So in terms of pupil size, now this was a small study, so probably not powered at this size, but pupil size and axial length, they didn't find there to be a significant correlation. They specifically looked at that because of one of the other studies that I'll discuss next. When it came to postoperative refraction, there wasn't a significant correlation between uncorrected intermediate and the magnitude of whatever the postoperative cylinder was in this case, but 73% of eyes with postoperative oblique cylinder achieved N6 of uncorrected intermediate visual acuity or better compared to 18% of total eyes. And so there is probably a little bit more digging to be looked at in the space of oblique cylinder being residual. Now, this is a concept afterwards that we've already been leaning on in terms of postoperative uncorrected intermediate visual acuity. It was obviously improved with a myopic spherical equivalent, which is obviously something we've been leaning on over the past few decades. In terms of spectacle independence, binocularity counts. So bilaterally implanted patients did actually have higher spectacle independence for intermediate tasks. In fact, over 50% compared to unilaterally implanted patients. And so that binocular summation also plays a role here. And the slight majority, about 55.3 patients of binocularly pseudophakic patients reported actually not requiring spectacles for any intermediate tasks as far out as 3 months. And they were close to about 1.7 to 1.8 fold more likely to be spectacle independent for both distance and intermediate tasks respectively if they were bilaterally implanted rather than monocularly. Now, we have had a discussion earlier today that there are currently, no ANSI or ISO standards for any enhanced monofocal IOLs. Points about this study is that, the current study really didn't record binocular uncorrected intermediate visual acuity because they wanted to avoid that skew. But when it comes to distance correction and intermediate vision, the addition of distance correction obviously caused a slight reduction in intermediate function, suggesting obviously small amounts of residual myopic refractive area might be actually necessary, and of course is a target when we're talking about our monovision or mini monovision targets. In terms of residual astigmatism, as we were stated, oblique astigmatism might actually improve intermediate function more than with the real astigmatism. And we look at maybe suggesting somewhere between 0.5 to 0.75 might provide better intermediate outcomes without a substantial degradation of overall vision, particularly for distance. And when we talk about spherical aberration now, the Clareon lens in particular does have an asphericity of about -0.2, and with the native virgin cornea having about +0.27, we can expect that the average eye might expect to have about 0.07 residual after implantation. And a study by Noches in 2011 showed that if we are targeting for around about 0.07 to 0.11, that might actually be a nice balance between achieving visual acuity and depth of focus. And in this particular study, there wasn't a statistically significant difference in the average corneal asphericity between those that did get uncorrected intermediate N6 compared to N8 or worse. But once the correction of spherical aberration was by the IOL was taken into account, the N6 group actually did have an average postoperative SA closer to the optimal range as suggested here. So in this study, the take-home points for me were that both the postoperative refractive target, which we've been employing for years, and lens design might actually be underlying mechanisms providing a little bit more intermediate vision than we expect, but mild residual oblique astigmatism might further enhance lens performance. But also, when we think about it, consideration of biometric factors might actually improve intermediate vision in terms of looking at pupil size and axial length. And this is a study by Morgan Micheletti that also came out quite recently to look at any refractive or biometric variables that might actually enable patients to achieve a little bit more. This is obviously with a competitor lens here, but quite a large study, investigator initiated at this prospective study here of 220 eyes with a fairly even spread between genders, looking at all of the demographic, biometric, refractive, and visual acuity data between the two groups. And we look at these, the only significant factor here was that pupil size is relevant. And this also echoes some of the work done by Damien Gattinel's group, looking at the way pupil size will influence the way your intended lens performs. They compared their enhanced group, the patients who were actually able to see a little bit more intermediate vision, and found that 68% of these respondents using these lenses rarely or never experienced any dysphotopsias, compared to 61% in the group that really didn't get a lot of enhancement in terms of their intermediate vision. And the enhanced group actually had a smaller mean pupil size compared to the non-enhanced group in addition to this. Not only did they find this, but the refraction doesn't seem to play a role in the enhancement of intermediate visual acuity with that particular lens, but certainly looking at smaller pupil sizes may actually help inform your counseling of patients or even your patient selection here. The Clareon monofocal toric or non-toric might actually provide excellent distance and functional intermediate for about 2032. And when we look at comparing these two lenses head-to-head, again, a study by the same author here, both of these lenses are a single-piece hydrophilic foldable monofocal lens with identical optic diameters and length, but a slightly different definition in terms of getting that enhanced monofocal from our competitor here. And this is again an investigator-initiated study, a prospective again at a single-center bilateral implantation of a fair amount of eyes, 620, with bilateral implantation of either Clareon or in the IHANS, with follow-up about 3 months afterwards, but included patients that were not necessarily targeted for ametropia, but also for monovision, although they did check the visual acuities with the best distance correction in place. And when we see this, they achieved about a 2.5 letter or a 0.05 logMAR difference in mean distance corrected intermediate between the Clareon and the IHANS. So not a huge amount of difference between the eyes. All subjects here had corrected distance visual acuity of about 6.9, 6.7.5 or better. And when you look at the binocular distance corrected defocus curves, they are actually very similar between the two groups. Just conscious of time here, but essentially non-inferiority compared between the two groups for distance corrected intermediate, and certainly the mean corrected distance visual acuity was similar for both the Clareon and IHANS. There may be room, there was an exploratory analysis here looking at a quarter of a diopter offset for the Clareon group to see if there was an improved, and demonstrated that there was a mean improved distance corrected intermediate at the cost of a slight decline, marking potentially that there is some benefit here of targeting slight myopia, which echoes a lot of what Professor Conan was saying earlier today. Thank you very much for your time. Thank you.